Good morning everyone. I am Dr. Divyakant Parmar, working as Associate Professor in Cardiac Anesthesia at UNMICRC. Under the Continuous Cardiac Education Program, we have started Transesophageal Echocardiography lecture series. As a part of it, I am going to talk on comprehensive transesophageal echocardiographic examinations. The outline of my talk includes starting from introduction, why complete TE examination is necessary, and how to insert probe, how we can manipulate probe, then image display, how to generate TE view, which structures we can get visualize, and how to apply clinically this view. Starting from introduction, transesophageal echocardiography has emerged as an essential imaging modality and a basic component in the practice of cardiovascular anesthesiology. That has led to the significant impact in the anesthetic management and thereby improving the patient outcome. Comprehensive TE examination is a systematic interrogation of the heart to provide consistency and quality assurance in the procedure. It should be necessary because of the following three reasons. It assists the physician in determining the application of TE and to improve outcome of surgical patients. It reveals an unexpected finding which is not diagnosed preoperatively, so that will have an important impact on patient care. Then we can record baseline findings after the induction of anesthesia, so that is used as a reference to compare post-operatively. In 1999, American Society of Echocardiography and Society of Cardiovascular Anesthesiologists jointly published guidelines for performing a comprehensive TE examination. Initially they have published 20 views. In 2013 they have added additional 8 views, so total 28 views comprise the comprehensive TE examinations. We will see one by one later on. First, how to insert TE probe. First, apply the jelly, lignocaine jelly over the TE probe transducer. Then perform a jaw lift by grabbing the mandible with left hand as you see in the figure, and push the probe with left hand. Just apply the constant gentle pressure with slight turning from left to right to find the esophageal opening. If you have resistance, then do not apply too much force while inserting the TE probe. And the most common cause is excessive extension of head and neck. So one can do the flexion of the neck, or one can use the laryngoscopy to insert the TE probe. Advancement of the probe is stopped after the head of the probe has passed the larynx and cricopharyngeus muscles, where one can feel the loss of resistance. So the probe lies in the upper esophagus. Now, how the probe can be manipulated? The entire probe is withdrawn or advanced. When the probe is pulling out from the stomach to esophagus, then it is called withdrawing of the probe. When the entire probe is pushing down from the esophagus to the stomach, then it is called the advancement of the probe. And the entire probe is turned to the right side, that is the clockwise, and to see the right heart structures, while entire probe is rotated to the left side, that is counterclockwise, to see the left sided structures. Now there are two wheels, one is the large and the small wheels. The large wheel is utilized to antiflex or the retroflex the probe. In antiflex, only the probe tip is bended anteriorly, while in retroflex the only probe tip is bended posteriorly. While utilizing this small wheel, the probe tip is pushed right or the left side, and according to that flexion to the right or flexion to the left can be done. while there is a transducer angle movement in which the entire probe remains still, but the transducer angle rotates from 0 to 180 degree, that is called rotating forward, and while angle rotates from 180 to 0, that is called rotating back. This angle of rotation occurs in a counterclockwise rotation, as you can see in this figure, and this also shown in this icon. So rotating forward from 0 to 180 degree. So during this rotation, the scan progresses from the posterior structures to the anterior structures. Now various TE window utilized for the visualization of the images, and for that probe position ranges from the upper esophagus to stomachs. These are the markings on the TE probe. According to this, approximately 20 to 25 centimeter upper esophagus cam and 30 to 40 centimeter mid esophagus view, and for greater than 40 centimeter transgastric and 45 to 50 centimeter for deep transgastric. So when the probe lies at the upper esophagus level, the structure closest to TE probe is the one of the great vessels, while at the mid esophageal level, the structure lies close to is the left atrium, and at the transgastric level, the structure is left ventricle. How we can see the image on the screen? The 2D TE probe displays the pie shaped sector on the screen. This is the pie shaped sector, and this is the sector apex, which is close to the TE probe. Right sided structures are seen on the left side of the display, while left sided structures are seen on the right side of the display. The structures which are close to the probe, these are the posterior structures, that is the near field, while structures away from the probe, that is in the far field, are anterior structures. So this is at the 0 degree, while at the 90 degree the superior structures are seen at the right side of the display, while inferior structures are seen at the left side of the display. So before doing this TE examination, we should connect the ECG cable to the patients, then adjust the 2D gain to get chambers black and tissue gray or white. We have to adjust the color Nyquist limit around 0.5 to 0.6, or whenever there is a low flow velocity, then we can decrease up to 0.3, 0.2. Then we have to start the examination at a sector depth of 12 centimeter. That is standardized to assess the heart size, and this is the rule of thumb that at transgastric view at 12 centimeter, the LV should fill up to third of the sectors normally. So if it fills more than this, then it is usually dilated LV. So we can assess the whether LV is dilated or RV is dilated depending upon. Now from this two-dimensional image, we can also assess the structure three-dimensionally. For that, we have to first center the structure within one image plane, then we have to rotate the angle from 0 to 180 degree while keeping this structure in the center. So it will assess the whole structure three-dimensionally. So to center the structure in an image at 0 degree, we have to turn entire shaft left or right, and at 90 degree we have to advance or withdraw shaft vertically. Now various approaches to perform TE study. First common is the view based approach, in which standard TE views are done in an organized or systemic way. That is most commonly used. Second is the structure based approach. So whenever there is a time is limited, or patient is uncooperative, or patient is hemodynamic unstable, then this approach is useful, in which we have to focus on only area of interest or only the specific structures, and we have to rotate the multiplane angle for visualizing that structures. Then third is the sequential segmental approach, that shows the arrangement of the atria, ventricles and the great vessels that in the congenital cardiac patients. So this is taken from the virtual TE website, and this is developed by the Peri-Operative Interactive Education group at the Toronto University, and this same shows the relationships between this various TE views and serves as a tool to navigate to the particular tool. So if we follow this same, then it will decrease the required time for whole comprehensive TE examinations and reduce the manipulations also. We will see one by one all of these view. First, this is the starting view, mid-esophageal 5-chamber view. So if we are at the 4-chamber view, then we have to withdraw the probe slightly till we can see this aortic wall and the alveoli. This is the 5th chamber. So we can see by putting color Doppler, if we can see any turbulent flow, then it will suggest if it is during diastole, then AR is present, and in case of systole, then it may be due to the septal hypertrophy. So this view is useful. In case of HOCM, we can take the measurement of this septal hypertrophy and length and width of the this asymmetrical septum, how much surgeon has to cut down. Then we can see the perimembranous VSD here, we can see muscular VSD here, and apart from this, this is the anterior leaflet of the tricuspid wall, and this is the septal leaflet as it is attached to the septum. This is the infralateral wall of the LV, and this is the anteroseptal wall of the LV. Rest of the features we will see in the mid-esophageal 4-chamber view. From mid-esophageal 5-chamber, we have to advance the probe till the aortic wall is lost. So this now we will get this mid-esophageal 4-chamber view, and we have to make adjustment up to 0 to 20 degree for to maximize the tricuspid wall annular diameter. We have to adjust the depth to include the whole LV apex, and sometimes retroflexion may be required to avoid the foreshortening of the LV apex. So we can in this view, this is the most important view in which we can assess the cardiac function and anatomy. We can say this is the home screen of this comprehensive TE examination, from which we can get each and every view. So the structures we visualize are all the 4 chambers: right atrium, left atrium, right ventricle, left ventricle. So we can detect any chamber enlargement present or not. Then we can assess the regional wall motion abnormality. This is the anterolateral wall, and this is the infraseptal wall of the LV. Then we can calculate the ejection fraction. Then we can also see whether RV dysfunction present or not. This is the RV free wall, and then this will cut the mitral wall into scallops. Especially this is the anterior, this is the A2 and this is the P2. While in mid-esophageal 5-chamber, we can see A1 and P1. This is the septal leaflet of the tricuspid wall as it is attached to the interventricular septum, while this may be anterior or posterior leaflet. If it is at higher level, if you withdraw the probe and it is higher level, then it is anterior, and if you push down little down, then it may be posterior. When we see the coronary sinus, then it is the posterior leaflet of the tricuspid wall. Now while putting on color Doppler of the mitral wall and tricuspid wall, we can also detect any mitral wall pathology, MR, MS, and tricuspid wall pathology, TR, TS. You can also assess. Then on putting color Doppler at the interatrial septum, we can also see any primum ASD, and we can also detect muscular VSD or the inlet VSD. And at the this is white structure we can see, that is the pericardium. So we can also detect whether any pericardial effusion present or not. Coming to the lower esophageal coronary sinus view, from the mid esophageal 4-chamber view, we have to advance the probe little bit and turn the probe right side. So this will brings the coronary sinus. We can see this in a long axis view as it runs in the posterior atrioventricular groove behind the mitral valve annulus, and this is the posterior structures. So what we can see here, that is the posterior leaflet of the tricuspid valve, and another is the septal leaflet. This view is useful when surgeon is inserting the retrograde cardioplegia cannula. And second thing, we can assess for TR, and third thing is that if it is dilated, suppose more than 1 centimeter in diameter, then we have to search for the presence of left SVC. Coming to mid-esophageal mitral commissural view. From the mid-esophageal 4-chamber view, we have to increase the angle up to 50 to 70 degree. That will cut the from LA center of the mitral valve and the LV apex. Some probe manipulation is required to show this image, which includes the 3 mitral valve segments starting from LA appendage, that is P1, in between A2, and this is the P3. So you can see 2 coaptation points, 2 papillary muscle, one is the anterolateral papillary muscle, second is the posteromedial papillary muscle, and LV apex should be seen without any foreshortening. When the entire shaft is rotated towards right side, we can see the whole anterior mitral valve leaflet, that is the A1, A2 and A3. While from this from the midline, if we turn the entire shaft towards the left side, then we can see the P1, P2, P1, P2 and P3 scallops of the mitral valve. So this view is useful for the mitral valve assessment, and we can see any commissural jet, regurgitant jet present or not. We can also see whether any LA mass or LA thrombus present or not, and we can assess the LV systolic function or regional wall motion abnormality. This is the anterolateral wall, and this is the inferior wall of the LV. Rest of things like pericardial effusion, mitral valve pathology can be detected. Coming to mid-esophageal 2-chamber view, from the mid-esophageal commissural view, we have to increase the transducer angle up to 90 degree. So that will shows 2-chamber, left atrium and the left ventricle, and RA-RV is coming out from the display. So from this view we can get this structures. This is the left atrial appendage, then this is the A2 part, that is the long anterior leaflet, especially long anterior leaflet, and this is the short posterior leaflet, and this is the posteromedial papillary muscles, and we can see this structure in the short axis, that is the coronary sinus, and this is the anterior wall of the LV, and this is the inferior wall of the LV. So we can also detect this, any wall motion abnormality present or not. If there is any smoky appearance in the LA, that is the spontaneous echo contrast, then that will, we have to look for any thrombus in the left atrial appendage. We can also measure the velocity of the left atrial appendage, and rest of this mitral valve pathology and LV apex pathology can be assessed in this view. This is the mid-esophageal left atrial appendage view. So from this mid-esophageal two-chamber view, we have to withdraw the probe slightly, and we can see this structure, that is the left atrial appendage. So this is the white structure, this is called commodian ridge, and above the left atrial appendage we can see the left upper pulmonary vein. For this view we have to make some antiflexion may be required. So we can assess the flow of this left atrial appendage, left upper pulmonary vein, and we can also see this left atrial appendage. So this left atrial appendage is a complex structure, and sometimes artifacts may be there, and we can not detect this thrombus present in the left atrial appendage. So it is visualized in a other multiplane angle also. Mid-esophageal long axis view. From mid-esophageal two-chamber view, we have to increase the transducer angle up to 120-130. Then we can get this image. This is the nice view, especially for the intracardiac air detection while coming off CPB, and these structures we can get visualized, especially the left atrium, left ventricle, and the aorta, and some part of the RV at the anterior side or RVOT. This is, we can see this A2 and P2 scallops of the mitral valve. So we can also see whether any systolic anterior motion of the anterior mitral valve leaflet is present or not, and we can see any regional wall motion abnormality. This is the anteroseptal wall, and this is the infralateral wall of the LV, and whether any aortic root pathology, aortic regurgitation or aortic stenosis present, we can also detect by putting the color Doppler, and we can also detect any subaortic VSD or perimembranous VSD here. So this is also very important view. This is the mid-esophageal aortic valve long axis view. From the mid-esophageal long axis view, we have to withdraw the probe slightly and to decrease the depth. Then we will get this image in which this is the LVOT, aortic valve, and the ascending aorta on the right side of the display, while some part of this posterior mitral valve annulus, and we cannot see the whole mitral valve, and we cannot see the whole LV, while we will see this RVOT part and the LA and the LVOT. So this view is useful for the aortic valve and the ascending aorta assessment. The LVOT is the 5 mm below the aortic annulus. This view is useful for taking measurement of the LVOT diameter, aortic valve. Then this is the sinus, and this is the junction, sinotubular junction, and from here the ascending aorta starts. So during the systole, we have to take this aortic valve annulus diameter, while rest of the dimensions are taken during the diastole. Coming to the mid-esophageal ascending aortic long axis view. From the mid-esophageal aortic valve long axis view that is made at the 120 degree, we have to withdraw the probe slightly and decrease the transducer angle around 100 to 110 degree. Then we will achieve this view. We can see the ascending aorta and pulmonary artery in the center of the display. The walls of the ascending aorta are parallel, and by putting color Doppler, if any color flow reversal is present, then that will suggest the aortic regurgitation if it is present during the diastole. Then any turbulent flow is present, then it will suggest the aortic stenosis. We can also detect any atherosclerosis in the wall of the aorta, or any dissection flap or aneurysm of the aorta present or not. And then we can also see any pulmonary position of the pulmonary artery catheter in the RPA, or any pulmonary embolism and the pulmonary artery. Coming to this mid-esophageal ascending aortic short axis view. So, from this mid-esophageal ascending aortic long axis view, we have to decrease the transducer angle to 0 to 10 degree. So, this will shows the, so we can get this image. This is the pulmonary artery which is bifurcating into the right pulmonary artery and the left pulmonary artery. We cannot see the left pulmonary artery because of the left bronchus which comes between the esophagus and the aorta. The RPA goes posteriorly behind the ascending aorta here, and we can see the SVC and the ascending aorta. So, this view is useful for this atherosclerosis of aorta, to see the dissection flap or aneurysm of the aorta, and if any aortic regurgitant flow present in the ascending aorta, then we can diagnose this aortic regurgitation. Then this view is useful for the pulmonary thromboembolism. We can see the thrombus in the RPA or the MPA, and we can also measure the gradient across the pulmonary wall in this view. We can see the pulmonary artery catheter, we can see confirm the central venous catheter in the SVC. This view is also useful for measuring the pulmonary artery cardiac output. Moving to the mid-esophageal right pulmonary vein view. This view is obtained by rotating the probe right from the mid-esophageal ascending aorta short axis view. As this vein lies on the right side, we have to rotate the probe right side, and it is usually, we can see this is the right upper pulmonary vein, and we can see the other structures. This is the SVC, just adjust to it, and the ascending aorta. This right upper pulmonary vein opens into the LA. So, by putting color Doppler or pulse wave Doppler, we can confirm the flow pattern of the pulmonary vein, and this view is useful to detect any anomalous pulmonary venous drainage present or not. In case this right upper pulmonary vein may open into the SVC in case of PAPVC, so we can see turbulent blood flow in the SVC. We can confirm the position of the central venous catheter in the SVC, and from the flow pattern of this pulmonary vein, we can also diagnose severe MR and left ventricular diastolic dysfunction. Now, if we want to see this right lower pulmonary vein, then we have to increase the transducer angle from 0 to 30 degree. Then we can see this right lower pulmonary vein also, because the right lower pulmonary vein is a parallel to the horizontal beam. So, blood flow cannot be detected. So, we have to increase the angle up to 30. Moving to the mid-esophageal aortic wall short axis view. From the mid-esophageal 4-chamber view, we have to withdraw the probe till the aortic wall is centrally positioned in the display. Then we have to increase the angle up to 30 to 45, and slight anti-flexion may be required, and all the 3 leaflets of the aortic wall should be symmetric inside. And here you can see this aortic walls in the center of the display. So, structures visualized are the left atrium, right atrium, this is the RVOT, and pulmonary valve. We can see this interatrial septum. So there are 3 aortic cusps. Among this is the non-coronary cusp, the cusp which faces the interatrial septum. On left side, that is the left coronary cusp, while towards the right ventricle, this is the, or the anterior, this is the right coronary cusp. So when we withdraw the probe slightly from this view, we can also see the left main coronary artery, as you can see, that will divide into the LAD and the LCX. So from this view, we can also measure the aortic wall area by using the planimetry. We can also see the morphology of the aortic wall, its whether any thickened margin or calcification, whether it is opening well or not, whether AR present or AS present, we can also detect from this short axis view. And from this by putting the color Doppler, we can also detect this PFO or the ASD. We can also measure the left atrial size, especially the AP diameter, and we can also see this pulmonary valve morphology, and we can also align the Doppler signal to measure the gradient across the pulmonary valve. Coming to the mid-esophageal RV inflow outflow view. From the previous view, that is the aortic wall short axis view, we have to decrease the transducer angle up to around 50, then we can generate this view. The structures visualized in this view are the left atrium, right atrium, 2 valves, 3 valves, tricuspid valve, aortic valve, and the pulmonary valve. So in tricuspid valve, this is the, we can see the anterior leaflet, and this is the posterior leaflet, and this is the RVOT, nicely seen, and this is the pulmonary valve, in which most anterior, that is the far field, that is the anterior leaflet of the pulmonary valve, and this is the left leaflet of the pulmonary valve. This view is useful for the any pulmonary valve or the pulmonary artery pathology, or to see any infundibular obstruction or RVOT obstruction present. Then we can also see whether any tricuspid ridges or tricuspid stenosis present. On putting color Doppler, we can also detect this defect in the interatrial septum, or we can also detect the VSD flow here. This view is obtained with the increase the transducer angle between 70 to 90, and we have to turn the probe towards right side while keeping the tricuspid valve in the center. This imaging plane is directed through the LA to image the right heart, including the right atrium, tricuspid valve, right ventricle, and the interatrial septum. So the structures we will get into this view are the left atrium, right atrium, and the right ventricle, and the tricuspid valve. So this is the anterior leaflet of the tricuspid valve, and this may be posterior or the septal leaflet of the tricuspid valve. So this view is useful to measure the pulmonary artery pressure by putting this continuous wave Doppler. We have to measure the tricuspid blood flow across the tricuspid valve, and this view is also useful to confirm the central venous line catheter. We can also see any pacemaker wire, and we can also detect this venous cannula position also. Moving to the mid-esophageal bicaval view. So for this view, we can get from this mid-esophageal modified bicaval view, we have to increase the angle up to 80 to 100 degree. Then we can get this view. The structures visualized are the left atrium, right atrium, interarterial septum and SVC, IVC. So this image cuts from longitudinally from the posterior to anterior, that is the left atrium, interarterial septum, RA and SVC, IVC. So we can see SVC on the right side and IVC on the left side and RA on the far field while LA in the near field. We can also see the right atrial appendage. So this is useful for detecting any ASD or sinus venosus ASD or any PFO. We can see the SVC IVC flow, then we can confirm the central venous line position and or any pacemaker wire, and during minimally invasive surgery we can also confirm the venous cannula position. Moving to the upper esophageal left pulmonary vein. From the mid esophageal long axis view, that is around 110 to 120 degree, we have to do extreme left side rotation, then we can get both the pulmonary veins. And the other option is that from the mid esophageal two chamber view, we have to withdraw the probe to see the left atrial appendage, and above the left atrial appendage we can see the left upper pulmonary vein. But to see the both pulmonary veins, we can use this view, and this both pulmonary veins occasionally seen as a inverted V as they enter the left atrium. So this left upper pulmonary we can see on the right side of the display, and left lower pulmonary vein on the left side of the display. So when we see the left upper pulmonary vein in the mid esophageal two chamber view, then after advancing the probe 1 to 2 centimeter, we can also see the left lower pulmonary vein. So I will finish my lecture today, including this mid esophageal and the pulmonary veins view. In the part 2, I will complete the transgastric and the upper esophageal TE views. Thank you.